Good morning, everybody. For those who came to who present in our meeting, we really appreciate your presence. And this is our second General Club of the year, and we were hoping that we can achieve to present something interesting every month through our reading or through our acquiring knowledge through journals. So today's my presentation will be on TEVI. A lot of people are unfamiliar with the word TEVI or TEVA. TEVA is more of an American term. It's actually transcatheter aortic valve replacement or implantation. So I find this. So this is a procedure that recently we have started in Mediclinic. So a while back, the implanters, or so-called the marketer or the designer of the company, Edward, had designed a trial to see the efficacies in critical aortic stenosis in an elderly population. So now since then they published this paper. So the title is Transcatheter versus Surgical Aortic Valve Replacement in a High-Risk Patients. I just want to run through a little bit of background. So basically, they understand that onset of aortic stenosis is associated with a high mortality if you leave it untreated. Untreated means surgical replacement in older terms. So aortic valve surgery improves symptoms and survival for those patients presented with critical aortic stenosis. But as time progresses, you will see that there is various subgroups. And I have listed it in front of the screen, which is advanced age, poor LV function, coexisting disease. And these patients are generally increase the risk for post-operative or operative complications and post-operative morbidity. So in this category, sometimes patients will be deemed non-suitable for surgery or very high risk, as the study has aimed to design to look at alternative, less invasive therapy. So in this randomized placement of aortic transcatheter valve, which is short named as a partner trial, this subgroup of patients who underwent TEVI, they just noticed two things. One, improvement of 20% in a 1-year survival, and then patient's symptoms has been reduced. So now just bear in mind, this background is talking about patients in a high risk population. I'm going to give you patients' characteristic now, and this is a randomized trial. So the method of the study is actually conducted from 11th of May 2007 to the August 28, 2019. The total had enrolled 699 patients with a severe aortic stenosis and a cardiac symptom NYHA greater than 2. This study has conducted 22 centers in America, 2 centers in Canada, and 1 center in Germany. Now, they define severe calcified aortic stenosis as aortic valve area less than 0.8 centimeters square, mean gradient at least 40 millimeter mercury, and peak velocity at least 4 millimeter per second. Now, the determinations of high operative risk was determined by cardiothoracic surgeon at each center and guided by Society of Thoracic Surgeon stratification scoring system. Now, they also exclusions. Exclusion criteria were bicuspid, non-calcified valve, coronary artery disease require revascularization, or a left ventricular ejection fraction less than 20%, and aortic annulus less than 18 millimeter or greater than 25. The others are severe mitral or aortic regurgitation, which is 4+, and recent neurological events. So the reason of exclusion criteria is that they wanted to randomize this high-risk population into a surgical group versus TEVI group. So they wanted to have an equal match of their population. And this is what I have mentioned now. And lastly is the severe renal insufficiency. In total, they have screened 3,105 participants, and 34% underwent randomization, 23 assigned to a high-risk group, which result has been reported here. Now, for those who do not know what TEVI or TEVA is about, is that the top picture depicted a severe calcified stenosis, and this is a transcatheter implantations of aortic valve. This is a balloon expanding valve, and by fluoroscopy positions of the valve, the new aortic valve has been implanted. My next slide has demonstrated various techniques or various assays to do this. But in partner trials, there were two groups being described, which is transfemoral and transapical. Although transapical, it's a smaller group that has underwent transapical implantation, but it does not skew the final result. So initial vascular assessment, so all these 3,105 patients went through vascular screening, 492 eligible for transfemoral, and 207 eligible transapical. But subsequently, they have randomized this population into two groups, which is a transcatheter group and surgical replacement group, which is 348, and surgical group is 352. Now, the reason they came about this number is that the sample of 650 patients will provide a power of at least 85% to show non-inferiority of transcatheter replacement as compared with a surgical replacement. And that's where that number came about. Lastly, the study endpoint is that now they wanted to compare the surgery versus transcatheter implantation. And the primary endpoint is actually rate of death from any cause at 1 year in the intention to treat population. The crossovers are not permitted, except when a finding during a assigned procedure prevent the planned treatment. And the secondary endpoint is multiple, is like renal failure, stroke rate, any other associated liver disease and all that, which I will demonstrate much later. So these are final, this is partner one, which is the initial design trial. Later on, they reported this partner two, which is the 2 years follow-up. So I will show you both the results. And these are the basic characteristics of the patient. If you look at the age, they are averaging between 83 to 84 years old in this population. And obviously, the male and female dominant ratio from the transcatheter replacement, males are much higher population. And then when you're looking at the STS score, you're looking at about 11. And logistic Euro score is about 30. Now, when you look at a lot of them are situated in class 3 to class 4 dyspnea. So these guys are already symptomatic. And they do have a concomitant coronary artery disease. Out of all, they have equal match in terms of amount of people had previous bypass surgery. And the rest is cerebrovascular disease. They all equally match. So when you look at the surgical replacement versus transcatheter, they almost had an equal number for previous PCI, balloon valvotomy, and all that. The next slide basically, the other concomitant disease like atrial fibrillation, previous permanent pacemaker, pulmonary hypertension. So when you look through the important thing is the frail condition, because that is more and more, although it's not statistically significant, but that's coming up, they are equally matched as well. So when you look at the patient's characteristic, both surgical and TEVA group or TEVI groups are pretty similar. Now, so partner one trial, basically the final result shows that the rate of death from any cause was 3.4% in the transcatheter group and 6.5% in the surgical group at 30 days. But it evens out almost 24.2 and 26.8 at 1 year. So there's a reduction of 2.6% in the catheter group. And basically it is significant. They look at the 95% confidence interval, and then p-value is 0.01, which shows its catheter group is non-inferior to surgical group at 1 year. Now, the rate of major stroke was 3.8% in the TEVI group and 2.1% in the surgical group at 30 days. And then, respectively, they have a higher rate on the TEVA group, which is 5.1% stroke rate, major stroke, by the way, and then versus surgical with 2.4% at 1 year. These are the two factors that come through at the results. So at 2 years, the similar pictures has evolved. Now, in terms of major vascular complications, they are more frequent with the transcatheter replacement group and versus the surgical group. But surgical group has a higher major bleeding rate. Now, at 1 year, so basically at the end, they basically says that at 1 year result, the TEVA group is non-inferior to surgery. Now we're moving on to the 2-year outcome after transcatheter and the surgical aortic valve replacement. There's lots of information there, and I just decided to put up slides. And then these 4 slides are basically the top 2s are death from any cause in the intention to treat group. And this is actually time to event curve. So you will see that the red line is TEVA group, and then the blue lines are the surgical group. So death from any cause in this intended to treat populations, you will realize that the TEVA and the surgery are very similar at 2-year duration, which is 36 months. And then the stroke rate, as we mentioned earlier on, as you see 2 years, the TEVA group is higher than the surgical group. But then they notice there is a surge at the 30 months, and there is an increase in terms of the major stroke at the surgical group versus TEVA. But statistically, overall, when they death from any cause of the stroke, they actually have no difference at the 2 years outcome. But in 2 years, as they reported, there's an important notice that I wanted to bring up. They say out of 699 studied patients, 42 did not receive the assigned therapy, 4 in the TEVA group and 38 in the surgical group. The main reason for non-treatment was withdrawal from the study and patient decision not to undergo surgery, which is 28 of them. Sorry, where am I now? Okay, so now this is the clinical outcome at 1 year, 1 year versus 2 years, because this is a partner 2 trial. And then when you looking at comparison, death from any cause, it's very similar. Death from cardiovascular disease, surgery, and TEVA are very similar. In terms of repeat hospitalization, slightly higher on the TEVA group. Okay, and the death from any cause or repeat hospitalization is similar. But out of all, the most significant are the last 2. The p-values are less than 0.001, are major vascular complications and major bleeding. Now, how do they define major vascular complications? The major vascular complication defined as a thoracic aorta dissection, SS side or SS-related vascular injury leading to death, the need for substantial blood transfusion, which is greater than 3 units, percutaneous or surgical intervention, and distal embolization, which is non-cerebral from vascular source, requires surgery and amputation. Whereas major bleeding was defined in any episode of major internal or external bleeding that cause death, hospitalization, or permanent injury that necessitate blood transfusion, at least 3 units of packed cell or pericardiocentesis. So you will understand open procedure in an age group of 84, they tend to bleed much more versus the TEVA group. So at 2 years, they define those, and you can see that out of the population, there were 95 in surgery had major bleeding versus 60 in TEVA group. And the major vascular complications are 13 versus 40. The reason of less vascular complication is that as cardiothoracic surgeon, we know what to do. So we decalcify, we wash the annulus, we will make sure that the annulus were clear of calcium as much as we can before we implant the valve. Whereas you see in the first pictures at TEVA, as they deploy the valve with the balloon dilatation, sometimes those microcalcium or microembolus can embolize to the brain as well as distally. Depends on the size of calcium and the location of the calcium. The rest of the parameter now, the last, it's quite important, which I think industry wanted to prove that in 2 years, there are no structural valve degeneration. But remember this, I mean, as we know that if you have a bioprosthesis in a younger population, they tend to degenerate faster. And this population is 85 plus. I mean, for them, probably need 10, 20 years before you see structural valve degeneration. Then from this study, they came up with the multivariate predictors of mortality. Now, the important thing is that, so basically what it says is that, what are we looking for in this category? What could contribute and say, you know what, we should lean in more towards one therapy versus the other? Now, they look at the various. Now, the important thing is the hazard ratio greater than 1, which is in a surgical group is STS score. They're using 11 cut off. And the liver disease significantly raised the post-op mortality. In a TEVA group, it's more of previous vascular surgery and stenting and the renal impairment because they're using contrast while demonstrating the locations of the patient. Now, this next slide is basically now they wanted to, the first picture is basically, they want to show you whether there is any degeneration of bioprosthesis. So with the surgical and TEVA group, you will see that in 2 years, the effective valve orifice has non-significantly changed much. So as the gradient after implantation. These two slides are basically, the interventional cardiologists say that TEVA is equivalently good compared to surgical implantation valve, basically. But it has proven that with the stats that in 2 years, at 2 years, TEVA and surgery, there's no much of gradient difference, then there's no much of decrease in terms of effective valve orifice. Right, through this, there is, this slide and basically says that through the time, so we're going to talk about result and limitation just now. So this slide, it basically demonstrated with TEVA, there are few factors resulted in this we so-called paravalvular leak and the aortic regurgitation. It basically depends on the study mentioned that in the early days when they designed the study, they do not really have 3D reconstruction or better visualization of calcium, location of calcium, the valve deployment angle. So therefore, after implantation of those TEVA valve, there is paravalvular leak. And so the study is trying to demonstrate in 2 years, they have demonstrated a detrimental effect, even with a mild paravalvular leak can increase the mortality. So that's A and B. Now, initially non to trace versus mild to severe, you can see that towards 2 years' time, there are significant mortality from mild to severe. But when you look at the B, they're divided into 3 groups, which is none or trace of paravalvular leak, and compared to mild and moderate. And mild to moderate ones that divided from the first is still seeing higher mortality compared to non or trace. Now, we're coming down to C and D, which is the aortic regurgitation. Remember, some of these valves, once they've been implanted by TEVA effect, due to the calcium, sometimes the valve does not sit appropriately, which require repeat balloon dilatation. And sometimes with a balloon dilatation or inappropriate alignment of the valve, it causes aortic regurgitation. And same thing as well, that if you have non to trace AR, you have a better outcome in 2 years compared to those who had mild to severe aortic regurgitation. They demonstrated a higher mortality at 2 years duration. So based on that, based on this 2-year study, they actually now start revising, thinking to improve the TEVA device in terms of with a better imaging, with the improved design in terms of skirting on the left ventricular outflow tract to prevent paravalvular leak and better position of aortic implantation, hoping that in future that TEVA has improved outcome post-implantation. Now, they have to conclude. So the result, the rate of death, if you're looking at the population, TEVA and the surgical group, they are at 2 years, they are similar. One is 33.9, and the other one is 35%. Now, the frequency of all strokes during the follow-up did not significant difference between 2 groups. But during the time when they're reporting, there are 8 additional, so basically they haven't included into their stats, is that there are 8 additional stroke in the TEVA group and 12 in the surgical group. Their conclusion is the improvement of valve area was similar with TEVA, and then surgical replacement was maintained at 2 years, and paravalvular leak was more frequent after TEVA group, and even mild paravalvular regurgitation was associated with increased late mortality. Thank you. Any questions?
Just a lot of comments. I think that when we started, the first case that was done was a morbidly obese patient in France by Alain Pugier, and the patient was in his 50s and he had no prognosis. No surgeon was brave enough to take the patient on. And that was the very first index case, and that's where the enthusiasm came from. That was, I think, 2003, actually, so it's a long time ago. And then, obviously, it became a good concept. The big problem for me as a surgeon is that when you do these operations, your debridement of the valve is meticulous. You take all the calcium out, and then you wash out the heart, so you don't send bits of calcium to the brain. The interventional cardiologists, well, they don't care about the calcium and where does that calcium go. We know they have a device they put in the aortic arch where you trap all the debris, and if you see one of those devices, it's full of calcium. So that's why they have less strokes with surgery, ironically, although it requires bypass and all the other terrible things that we do to patients. The attractiveness of TAVI is obvious. You don't need to have your chest split. And a lot of patients, you know, who are young and need valve replacements are now wanting TAVIs because it's, you know, it's better. But the big problem again is age-related valve degeneration, which means you're going to have another valve, and the cardiologist will say, well, you'll do a valve in valve. But the evidence for that long term is also not great on valve in valve. Where do we go with that? You've got to put a smaller valve inside a big valve. So it's not the answer to aortic stenosis, not the complete answer, and there's still a place for surgical valve replacement. And you know, less invasive options are available on that as well. But it's interesting to see that the stroke rate was similar after 2 years. That's not related. I think it's kind of a silly comparison on 86-year-olds. 86-year-olds have strokes. You've had your surgical valve and no stroke, so there's going to be an attrition as you age in strokes, whether it's atrial fibrillation and cardiovascular disease. And then the definition of major bleeding being transfusing 3 units of blood. A lot of the old patients have comorbidities, and their figure was 19%, which makes it sound like they had a lot of surgical bleeding. The average surgical bleed after open heart surgery is between 1 and 2%. So if you take the older patients with maybe softer tissues, maybe you could make that 5%. So that's a major bleed in my opinion. In fact, that an 86-year-old patient who's probably, you know, not in the greatest shape, needing aortic valve replacement, I think 3 units of blood doesn't represent a catastrophe. And it's a nice statistic to make surgery look worse, I think. But I think, you know, it's the way, if you torture your data enough, it will eventually confess. And just a cynical note, this is industry driven. The price of the valve was 275,000 Rand for a TAVI valve, and for a normal surgical Magna Edwards prosthesis is 34,000 Rand. And that's where all the money is. That's where, you know. So I think we've got to interpret all of these things with a little bit of caution. TAVI is wonderful. It is wonderful. But it doesn't fix everything. It doesn't fix the small aortic root. It doesn't fix endocarditis. It doesn't fix the patient with ascending aortic aneurysms or severe mitral regurgitation. It just means that the surgeons, like with stenting coronary artery disease, you're operating on worse and worse and sicker patients. So the surgeons have got to front up a little bit now. And they need good anaesthetists to help them do that.
Okay, so I've got the privilege of speaking about something very exciting today. I don't know if anyone's been hearing this word ERAS flying around everywhere and wondering what is this that everyone's talking about. So today I'm going to discuss just a quick intro about what this ERAS story is. And I'll be the ERAS coordinator for the JJ&J program. And my name is Renee Gomes. For those out there on the virtual chat, thank you for joining us. Okay, so ERAS is an acronym for Enhanced Recovery After Surgery. There's many tracks of ERAS, many programs. Can you see it? Okay, there we go. Okay, so the track that we're dealing with is ERAS cardiac. There's many, like I said, for all different disciplines. And if you go to the ERAS cardiac website, you'll see it says there that it takes a large team of healthcare professionals to care for someone having heart surgery, which we know, we can see in this room. Through a combination of knowledge, hard work, and cooperation, patients can have the best recovery possible. And there's a Society for Enhanced Recovery After Cardiac Surgery, ERAS Cardiac, and their mission is to optimize perioperative care of cardiac surgical patients through collaborative discovery, analysis, expert consensus, and dissemination of best practices. Okay, so these stats are for, some of them are for North America, but let's just have a look. In perfecting the surgical journey, cardiovascular disease is the #1 cause of death worldwide, all right? In North America, they do 377,000 open heart surgeries, and that was in 2014. Okay, and 80% of the cardiac surgical morbidity that occurs outside the operating room. So here's looking at you, ICU practitioners. Okay, we can make a huge difference to prevent that. Okay, and then they also shown that they've reduced the time in hospital for patients undergoing open heart surgery by 24 hours if they introduce the ERAS protocols. So in South Africa, we're not really sure of our own statistics, which is quite shameful. I think I read somewhere it's about 8,000 open heart surgeries a year, but that was also quite old information, 2014, also around there. Okay, I wonder what our cardiac surgical morbidity rate is outside of the operating room. I'm not sure if anyone's willing to make a guess. Okay, and I'm going to put my neck out and say, I personally think we can have more than 24 hours in reduction of our patients' time in hospital when undergoing open heart surgery if we implement these guidelines. Okay, so how do they make these recommendations? Who does it and how do they do it? So it's a multidisciplinary, which I appreciate so much as a nurse myself, systematic review of current literature. Okay, potential enhanced recovery interventions are identified, supportive data are collected from existing publications, and the proposed interventions are then evaluated through a collaborative process to achieve expert consensus on the current items recommended by ERAS Cardiac Society, including the grading of the quality of evidence, which they give with the guidelines, which is great as well. This is some of the committee of these people that work this all out. This first section here is the executive board. And if you look, I don't know if you can see that lady right at the bottom on the left. Her name is Vicky Morton. She's a registered nurse, a critical care nurse. And we've actually made contact with her to guide us, to help us to start ERAS within our practice and the patients that we serve. The rest are all advisors. They come from all different countries. I see a lot of USA, Canada, Germany, and there is a UK here and there as well. Okay, so this isn't some person sitting in their mother's basement figuring this out. These are respected experts that know what they're doing, and they do it in such a beautiful scientific way. So we're going to have a look at these guidelines, but I want to quickly just show you, in case you're wondering about all the little codes and colors. They give us a class of recommendation, and you can see that green is very strong, okay? And then it goes to moderate yellow, orange is weak, and then the reds are no benefit and harm, okay? Those are the class or strength of recommendation. Then they're also going to give us a level of evidence, the best of which is level A. Okay, so that's really good evidence that supports the statement. In between is randomized and non-randomized trials of evidence, okay, which is that lighter blue. And then the lightest blue is then limited data or just an expert's opinion, which personally I would still take an expert's opinion from that group of people. And that's the lowest level of evidence, okay? So let's have a look what they say. It's not that complicated, and I'm sure some of these things you'll actually recognize we are already doing. We just need to do it all and all be on the same page and do it consistently. Okay, so let's have a look at the first one. Tranexamic acid, does anyone know what that is? Cyclocapron, okay, is recommended during on-pump cardiac surgical procedures. All right, so that's the strongest guideline that they've got in their guidelines, because we can see it's got the level A evidence there. Okay. Next one is perioperative glycemic control is recommended. All right. And when you visit the site, this is just the summary of the guidelines, but you can click on each one, which I'm going to show you one example, and it will give you more information about how to achieve this. Okay. Next one, a care bundle of evidence-based best practices is recommended to reduce surgical site infections. And I'm sure all the hospitals know the SSI bundle. Okay, that's what we'll follow. Then, this is my favorite one at the moment. You shouldn't have favorites, but goal-directed fluid therapy is recommended to reduce post-operative complications. Can anyone tell me how we do that? What is goal-directed fluid therapy? Do you think it's goal-directed if we stand around the ICU bed with a low blood pressure, a non-transduced CVP, and say, no, give fluid, give fluid. And then you say, why? And you say, because I just know, just give fluid. Do you think that's goal-directed fluid therapy recommended to reduce post-operative complications? No. So the way in which we're going to do this is we're going to apply our cardiac output monitor. Okay. All right. We're going to use science, gather the data, and then use the algorithms provided to us to make decisions. Okay, we don't need to fly off the seats of our pants like cowboys and I know better, and no, I know, and just use the science. They've already worked it all out for us. Okay. Okay, a multimodal opioid sparing pain management plan is recommended post-operatively. Okay, so we're going to get onto a protocol for pain management. We're not going to have everybody doing their own thing. We need to spare the opioids because you'll see later on there's a very high recommendation to extubate early. So we're not going to have someone sleeping on a ventilator. They need to breathe, but also be pain-free so that they can mobilize and do all the things that they need to do. So this one, I think, is going to take a bit of work and a bit of a mind shift for everyone to get onto the same page. And we're going to need all the doctors to agree that we're going to implement the guideline. Okay, persistent hypothermia after cardiac pulmonary bypass should be avoided in the early post-operative period. Okay, I think we've noticed the people that have been doing this for a number of years. In the past, the patients used to come out of theater extremely cold. And we used to have to warm them slowly so that they didn't get too warm too quickly and vasodilate. We had all these considerations. But nowadays, they come out of theater and they're already almost normal temperature. You hardly have to do anything, except monitor it. Okay, we have to use a core body temperature. They've been on bypass to make sure they've got normal temperatures. It's catastrophic, and to have an abnormality here. Okay, what can happen if you're hypothermic? Do you want to share, Dr. Fulton? How important is hypothermia? Yeah. What will happen to the patient? How come? VF and bleed. Do you think bleeding might be something we would want to avoid after heart surgery? Who's looking at the temperature? I'm telling you, it's not the surgeon. He's just finished the operation. He's finished. Who's looking at the temperature? The ICU nurse. That is your job. That is your baby, and it is so important. Okay. All right. Maintenance of chest tube patency is recommended to prevent retained blood. Post-operative systematic delirium screening is recommended at least once per nursing shift. Okay, I know that Mediclinic has got this checklist on their ICU chart. I'm not sure what the other hospitals do, but we're going to have to look into that one. Okay, smoking and hazardous alcohol consumption should be stopped 4 weeks before elective surgery. Obviously, that's elective surgery, so it's not the person that comes in with chest pain. Okay, it's the ones that know they're going to have surgery. The ones on a waiting list on the NHS. Okay. Early detection of kidney stress and interventions to avoid acute kidney injury are recommended following surgery. And we discussed some of those things in our last journal club. Rigid sternal fixation can be useful to improve or accelerate sternal healing. So that's going to be a bit different too. We've seen it used here and there. Don't know how you guys are going to apply that and to who, but you'll have to figure out how we're going to use it. So basically a plate, plates and screws instead of our sternal wires.
It's more expensive, and we generally use it for large patients, and then worry about the wire, what she's wiring. But the argument is that double wire is as efficient as the sternal plating. But my preference was, the bigger patient, the BMI, and I use sternal plating for the sternal fixation part. But it does work well. They have less pain afterwards.
I think that's what they're trying to get away from in ERAS, is personal preference, rather evidence-based. And there are, even in the ERAS committee when I was at the AATS in Boston, there are absolute enthusiasts, and they were being tempered by, like Dan Engelman, who's the chairman, I think, sort of saying, well, not on every patient. And then it's guys saying on every patient. So I think what they, the nice thing about it is that it looks really nice. I mean, it might sound silly, but these beautiful blue plates with colored screws, and it looks beautiful, much better than wired. And that's, like I say, it's nice. They're nice to use. They are expensive, but they show clear evidence-based benefit in the cohorts of patients that they chose, which is usually the elderly with osteoporotic sternums, as well as what James mentioned, the big fat patient who is our nightmare. But there is quite an expanded indication for it, and even bilateral mammaries, those kinds of patients. So that is we're probably going to have to change our practice, but get the funders to pay for it. That's like TAVIs. Got to get the funders.
How does it work in a emergency situation where you have to open the chest again?
They've got there's a whole variety of different plate types. There's ones with a little pin. You just pull the pin out, 1, 2, 3 pins, and it pops open. And that would be the preferred one to use for these patients.
The titanium plate one, they provide two things. If you've got time to unscrew them, you can. But if you're really in an emergency, they've got a cutters. So it's a H plate, and then on top is a diamond, and then L plate. So you can cut, and then split. The only problem is that the second time when you screw in, you have multiple screw already. And those screws that you're using is self-driven screw. And then the second time you probably have to use the lock screw, which is the purple, if you already had a hole in it to secure so it doesn't really move.
Okay. Next one is prehabilitation is recommended for patients undergoing elective surgery with multiple comorbidities or significant deconditioning. And I think we'll apply this to all our patients that we see. As the ERAS coordinator, I will see them as well before and after their surgery. We'll have a follow-up program. But the prehabilitation is something that we'll have to really drive and focus on, depending on the patient's needs, what they might need physio beforehand, whatever their needs are. We're going to speak about optimizing the nutrition and all that just now. Okay, next one, an insulin infusion is recommended to treat hypoglycemia in all patients post-operatively. Okay, that's quite clear. Strategies to ensure extubation within 6 hours of surgery are recommended. And I think you've seen in this last year or last 6 months, our doctors have already implemented that pretty much. And I think it's been quite a difficult mind shift, because it's so nice to look after these patients until the next morning when they're nice and calm and ventilated. It's a lot more work, it feels like sometimes, to drive that 6-hour extubation. But it's so good for the patient. By the next day, we're so far ahead of the journey. They're awake, they can mobilize, they can do things, they're not in a stupor, they can start eating. They feel better already by the next day, as opposed to waiting for the doctor to come on the rounds. 8, 9 o'clock we extubate. By lunchtime, they're still feeling the effects of the sedation. In the afternoon, oh, it's too late now to put the patient in the chair, and you're a whole day behind, okay, on the recovery. Okay. Next one, patient engagement tools, including online application-based systems to promote education, compliance, and patient-reported outcomes are recommended, which we're going to work on. Chemical thromboprophylaxis is recommended following surgery. Preoperative measurement of hemoglobin A1C is recommended to assist with risk stratification. Are we doing that already? No. Okay, so that needs to become protocolized. Okay, so I just quickly wanted to show you. So now if you click on, and I chose my favorite one, the goal-directed fluid therapy is recommended to reduce. It tells you that class of recommendation, it's strong, the level of evidence is a randomized trial, okay? And then if you look at the main points, I've got a slide with them, and then you'll see all the references that they've used, okay? There are the 4 main points. So goal-directed therapy utilizes monitoring techniques to help guide clinicians with administering fluids, vasopressors, and inotropes to avoid hypotension and low cardiac output. Yay, we don't have to rely on our gut feel anymore. We can rely on monitoring. Clinicians employ various therapeutic strategies targeted to achieve predetermined parameters for blood pressure, cardiac index, systemic venous oxygen saturation, urine output, oxygen consumption, lactate, and other biomarkers. Okay, post-operative goal-directed therapy in cardiac surgery patients has demonstrated reduced length of stay and infection rates, as well as less occurrence of low cardiac output syndrome. The full utility of goal-directed therapy, including its application in the intraoperative phase, requires additional study. Okay, that's why it's not that strongest evidence. It's because of that point. All right. Okay, and then a shameless plug, which seems very appropriate right now, is that we're having a cardiac output workshop. It's going to be fantastic. On the 8th of March, we've got an expert coming out from the Netherlands, from Gettinger Surgical Innovations, that's going to do an interactive workshop with us on how to manage the cardiac output monitoring. I'll also be doing a short talk before that about the basics of cardiac output, just so that's refreshed when the guy starts talking about it. Okay, but he's definitely the rock star of cardiac output monitoring, and I feel like we're all going to level up in a big way after this workshop. So please try and come if you're going to be working with open heart surgery patients. I appeal to the anesthetists and doctors also to support this. Okay.
Thank you, Renee.
I'm not finished.
Oh, you're not done yet. Sorry about that.
Don't pretend like I'm the one who talks the most, Dr. Chen. It's definitely you. Okay, so just quickly, I won't go through all of them, but those guidelines can be broken up into pre-op, intra-op, and then can you see the ICU people, post-op? Most of the work is ours. Okay. All right. Okay. I just quickly wanted to have, maybe if just 1 or 2 people will comment. What do you guys think of this ERAS story? Does it feel overwhelming to you? Who do you think this will benefit? And you can talk in the perspective of a patient, a doctor, nursing, multidisciplinary, the hospital, the medical aid, the patient's family. Do you think there's benefits for everyone?
Yes.
As a nurse, I would just love to have this protocol and be able to mix the medication before the patient comes out and not be like, okay, this anesthetist wants this surgeon likes this. You know, you have to know everybody's likes to be able to treat the patient. That's now gone, and we're going to all be working the same way, guided by science. I feel like it's so empowering. I mean, the days that the patients are going to be spending in ICU is reduced, and in the hospital. That's massive benefit. That's the best benefit. Not putting them at risk for all sorts of infections and clever bugs in the ICU. They also will be receiving a lot more information, so they're going to be more educated about this process. Do you guys maybe want to say anything from your side? Are you excited about it? Yeah.
I think it also links us all together.
Yes, it's a multidisciplinary thing.
Separate, and protocols link people.
Yeah. Yeah. I hope everybody's excited about this. We're making a commitment that we are going to launch this program for all our patients on the 1st of May this year. So we've got a few months left to educate everyone and to design our protocols so that you've got them in your hand and they're available. And then also to design something for our patients to take with, whether that's a little passport booklet or something for them to take along the journey. If anyone has any questions about the program, you're welcome to contact me. I also just wanted to say that this is the first time that anybody's doing ERAS cardiac in South Africa. Okay, so it's really exciting to be part of. We're about 5 years behind. All right, this is 5 years old, this program. We're supposed to be presenting new things in Journal Club, but this is new for our country. Okay, and I think we're actually in a good area to do it because we've got the 3 doctors that work in such a big region. The teams are enormous. You know, it's 5 different ICU teams. There's a lot of anesthetists involved. So this is actually really great to get us all on the same page. I think if anyone needs the ERAS program, it's us. Okay. Okay, cool. Thank you. I'm going to hand it over to Omi if there's no questions.
Is that okay? It's good morning to everyone, and thanks to JJ&J for the opportunity to talk about nutrition. I'm trying not to take offense from the slide that Renee shared. There was very little mention of nutrition there. But I think the more opportunities us as dietitians, we've got Amy in the room as well, the more opportunities us as dietitians get to talk about nutrition, it can actually widen the voice and improve the outcome of patients. These are just some of the disclosures. I do various talks with different companies. I'm on the scientific advisory board for critical care nutrition for ADCOC and receive fees for speaking from different companies. In terms of shameless punts, following Renee's slide there, for anybody in the room that has an interest in critical care nutrition, I host a podcast called Healthy Conversations with Omi Naidu. Renee shared a slide where there were experts from the ERAS international body, and 2 of them, Professor Christian Stope and Prof. Arvid Weimann, they've been on the podcast twice. And if you've got an interest in critical care nutrition, it's something you can listen to while you're driving to work or in the shower, and it just further enhances your knowledge of where nutrition fits in. The talk for today, I'm going to try and whiz through it. I know we're running behind schedule. We're going to cover the ERAS summary in terms of nutrition, look at the effects of surgery, the impact of the patient's nutritional status on the surgical outcome, and then looking in terms of early preoperative phase, the late preoperative phase, and then the post-op. And I just included a few slides in terms of health economics, as well as the conclusion thereafter. So if we're looking at the ERAS protocol, where does nutrition fit in? In the early pre-op phase, nutritional screening is definitely something that needs to be done, and it's part of the ERAS protocol. For those patients identified at risk of malnutrition or having malnutrition, some of the studies show that they should get some nutritional supplementation for up to a week. Thereafter, if we're looking at the late pre-op phase, and I know we've got the anaesthetists in the room as well, carbo loading, a lot of the ERAS guidelines look at patients not having the prolonged NPO periods, which we'll touch on a little bit later. And then post-operatively, early enteral nutrition, and looking at making sure that these patients, after this huge catabolic event that we call cardiac surgery, that we actually are providing them with enough nutrition to not only survive the actual surgical intervention, but also improve the functional outcome of these patients. What are we letting back out into the community? Just in terms of the effects of surgery or the metabolic effects, I'm sure we're all familiar with it, but just with surgery and cardiac surgery, the patient ends up having a systemic inflammatory response, and we have a surge of the hormones and cytokines, and the net effect is that you have breakdowns of protein, fats, as well as we know that there's marked insulin resistance, and the patient presents with hyperglycemia. With the protein breakdown, it's not only a loss of lean body mass, but it also affects wound healing as well as the patient's immune function. Okay, just the success of surgery does not depend exclusively on the technical surgical skills, but also on the metabolic interventional therapy, taking into account the patient's ability to carry the metabolic load, as well as our ability to provide them with the appropriate nutritional support. In patients undergoing cardiac surgery, management during the perioperative period is definitely crucial in terms of the long-term outcome. If you look at the impact of the nutritional status on surgery, malnourished cardiac patients have been shown to have poor wound healing, delayed weaning from mechanical ventilation, increased length of hospital stay in the ICU, higher costs, as well as shorter survival time. You know, the sort of interesting point about the slide is that malnutrition is something that's completely preventable. Yet, unfortunately, we have these patients that end up in our systems with a very poor nutritional status. So I think we all have a role to try and identify these patients sooner and have a tailored intervention for them. Iatrogenic malnutrition is also associated with patients who undergo cardiac surgery and are mechanically ventilated. I just wanted to share a study from a local study that was done where they looked at academic hospitals where things are meant to be working well and the systems are great. And one of the hospitals that was involved was in Cape Town and a couple in Africa. And they wanted to look from an observational perspective, how significant is hospital malnutrition? And what the findings were that 61% of patients that were admitted in these academic hospitals were considered to be at risk for malnutrition. And due to it being observational in nature, you'll see that at admission and by discharge, the percentage then went up to 71%. Meaning that even in the academic settings where resources are quite abundant, very little was done to correct this problem of hospital malnutrition. The study also found that 2 in 10 patients were actually at risk of malnutrition, were even referred for nutritional support. So meaning that many of them that were classified as having malnutrition were not actually referred for some sort of nutritional support. And only 8% were referred within the first 48 hours. A lot of the guidelines say in order to have a better outcome with these patients, we need to intervene timeously. So the shocking stats was that very few did get referred, and when they did get referred, it was very late in the system. Then when we looked at, not to point fingers, but then they looked at disciplines, you'll see that from the departments, you'll see cardiac surgery, around about 60% of the patients were classified as having hospital malnutrition. So exactly the patients that you guys are touching, exactly the patients that are within the journey of the people in this room, 6 out of 10 of them are having a poor nutritional status. The guidelines or the recommendation from the study was that we need early screening of these patients, which is in line with what ERAS talks about. We also need to look at timeliest nutritional intervention, but also there needs to be somebody, and this is where the dietitians come in, there needs to be somebody monitoring what is this patient's daily intake versus their requirements. Very often we may have a nurse even ask us, what is the need for these supplements? The patient may have a bit of loose stools, and there's so many other things that could be triggering the loose stools, but immediately it's a supplement. I'm sure the story is not unfamiliar to many. But very often we say they're eating, but how much are they eating? How much of protein? How much of calories? Is anybody measuring that? And this is where the dietitians come in to supplement where the deficits are. This is from the European Society of Parenteral and Enteral Nutrition. Their recommendations were that the influence of nutritional status on post-op mortality and morbidity has been well documented, and inadequate oral intake for more than 14 days is associated with higher mortality. Not specifically with cardiac surgery, but with many patients that end up in the ICU with the ICU nurses. We often know sometimes these patients can go for 2 to 4 days before anybody decides what we're doing from a feeding perspective. So just to know that this directly impacts on the patient's outcome, and trying to intervene sooner is definitely going to help. From ESPEN, they also say undernutrition has been shown as an independent risk factor for complications, mortality, increased length of hospital stay, as well as increased costs. Then we're looking at, so we know with ERAS, they look at specifically pre-op, intraoperative, and post-op. But from the nutritional perspective, we sort of subdivided into the early pre-op, and this is where we look at screening tools. There's an abundance of screening tools that can be used. We use the NRS, the first one at the top there, the NRS 2002. And these are tools that take under 5 minutes to carry out, even under 2 minutes for a dietitian or a nurse to do, but they're clinically validated to identify patients at risk. The whole message is we want to identify people that have a poor nutritional risk, keep a close eye on them, and those are the people that have been shown to benefit from aggressive nutritional management. These are just some of the templates here. And then from Duke University, they've got a very well-established ERAS protocol, and they use something called the PONS, which is the preoperative nutritional screening tool, where they look at the body mass index, unplanned weight loss, the patient's oral intake, and if the patient answers yes to any of that, they then look at their albumin. If it's below 30, then there's somebody that needs to see a dietitian urgently. This is a very old study, but I think the studies over the years have shown us that preoperatively unintentional weight loss does have an adverse post-operative outcome. And it makes sense that all of these tools that we've shown here, they have an element where they're looking to see what is the unintentional weight loss of the patient. This is just talking similar to that, preoperatively, this is Espen's guideline, that albumin is a prognostic factor for complications after surgery. We know that albumin is affected by, many other things, including inflammation. So it's not always a good marker of nutritional status, but it is a prognostic factor or prognostic tool for patients having complications after surgery. Then if we're looking at the preoperative carbo loading, I'm sure everybody's familiar with this, but we know, as we said, that with surgery, there's marked insulin resistance. And one of the strategies to address the insulin resistance is the carbo loading, where we give them clear fluids up to 2 to 4 hours before surgery. In terms of insulin resistance, we know that the severity is related to the magnitude of the operation and the development of complications such as sepsis. And we know that the carbo loading is one of the strategies to reduce insulin resistance. When we're looking at preoperative fasting or extended fasting, we know that this increases the catabolic stress. From our previous slide, we know that it worsens insulin resistance. It further worsens any nutrient deficiencies that the patient may have already, and also reduces immune function. This is just a slide, not specifically cardiac surgery, but in different types of surgery showing the benefit of carbo loading on insulin resistance. And also what we refer to as minor hyperglycemia, a study showing how the post-operative hyperglycemic events increase mortality in our patients post-operatively. From Espen, which is our guideline body, they found obviously that the preoperative carbo loading also reduces length of hospital stay. And there is a question as to whether other items like glutamine and other antioxidants and anti-inflammatory ingredients may benefit these patients. As the other slides showed, when they go into surgery, there's quite a surge of all this inflammation and all these hormones and cytokines. So it would make sense that there may be some benefit. However, the research is limited. Then if we're looking post-operatively, the benefits of early enteral nutrition definitely documented their reduction in wound infection, reduction in mortality. We know post-operatively we want to try and feed the patient orally or enterally. We know that enteral nutrition promotes gut proliferation. It maintains gut integrity and enhances the immune function. When we have prolonged periods of starvation, we know that your cytokines are already elevated post-surgery. When we have the starvation periods, it increases gut permeability. It's at the bottom here. And then we get bacterial translocation through the gut, which then increases the risk for multiple organ failure. So something as simple as feeding the patient is a huge mechanism of protection in making sure that the patient doesn't go into multiple organ failure. So we know early enteral nutrition is important, but many of the cardiac surgery studies that have been done show that we only reach 20 to 30% of their energy and protein targets. So often, people are feeding these patients, but we're not getting to the targets. And there's various reasons for this. There could be gut tolerance issues. There could be volume restrictions that we're dealing with. We know drugs such as vasopressors affect gut absorption. There could be hemodynamic instability. And then the one thing that lies with many of the people in the room, which is feed interruptions. Very often we may get to the patient's bedside and there's no valid reason why the feed has been stopped for 6 hours, or why is the feed being switched off after one very small aspiration. So there's multiple reasons as to why patients after surgery also may not be meeting their targets. This was just a study where the blue line represented what the patient required, and on the red line what was actually being delivered to these patients post-operatively. And you can see this huge gap here of energy, of protein. And for these patients, they typically are not going to be having a good outcome post-operatively because of them firstly not meeting their requirements. And also we know that even prior to surgery, many of them present to hospital with a poor nutritional status already. So we know in these post-op patients, we've got a low protein intake. The data is quite evident. We've got inflammation, which is something after surgery that's quite common. And we know that these patients are immobile because they're in hospital for prolonged periods and they're also in bed or they may be sedated. Now, all of these three factors are sort of the recipe that causes sarcopenia, which is the loss of muscle mass. And it's this sarcopenia that not only reduces immune function, but it then affects the functional recovery of these patients. We are doing great surgeries to improve their lives and save their lives, but there is something in terms of nutrition that we could do that could improve their functional outcome. The other thing is parenteral nutrition should be started within 5 days of patients not being able to meet their requirements. Also, parenteral nutrition can be seen as a top-up to meet their energy and protein. If you remember anything from the slides that I've said today, just remember the 20 to 30%. It's not our center, it's not one center, but it's a global stat of cardiac surgery patients meeting 20 to 30% of their requirements. So we've got these catabolic patients that are wasting away, and it affects their outcome. We know that combination enteral and parenteral has been shown to increase functional recovery in the critically ill patients. And according to various meta-analysis and guideline recommendation, parenteral nutrition is not associated with higher infections, nor delayed recovery, nor higher health costs. So the benefit of meeting the patient's requirements supersedes the potential or the perceived risk of higher infection. These are just some ESPEN guidelines, but just to talk about Highland et al., Prof. Highland was also somebody who's been on the podcast and spoke at length of parenteral nutrition in surgical patients. Him and his group have done a meta-analysis of 27 studies for PN patients, and what they found was, whilst there was no effect on mortality rate, there was definitely a lower complication rate, and there was a better benefit for those that were malnourished. The author at the bottom, I'm going to pretend that I know how to pronounce it, Braunschweins, not sure if anybody wants to do it, but Braunschweins et al. Did a similar meta-analysis, and what they found was that PN had a significantly lower mortality rate and a tendency for a lower infection rate. For those patients when extubated, we know that ice chips are allowed. Their diet may be advanced as tolerated, as long as they have some sort of swallowing evaluation. And some of the guidelines suggest chewing gum may promote bowel motility, and that's also quite controversial as well. Just a few slides in terms of health economics. Melnick et al. In 2015 showed that ERAS implementation, so not specifically nutrition, but ERAS implementation equated to a cost saving of roughly almost $7,000 per patient. Then Mullen et al. In 2018 did a study of nearly 1 million patients, and what they found was for every $1 spent on oral nutritional supplements, it equated to a $52 cost saving in terms of the healthcare costs. What they also recommended was that ICU survivors, or as we have our cardiac surgery patients who sometimes may be in ICU for some time, they would need 3 months of high protein oral nutrition supplements. From the study, what they also found was that a very small portion of the patients actually received supplements even when they were classified as being malnourished, and that oral nutrition supplements were associated with 40% fewer 30-day readmission, as well as the timing of ONS was associated with shorter length of hospital stay. Just a quick summary there. If your patient has oral nutritional supplements, there's various benefits besides the cost. We said mortality, morbidity, complications, and shorter mean length of stay. And it ties into the story, 20 to 30% of the requirements are met. So it's logical if we are supplementing them with more protein and more calories, that we are sort of reducing their burden of disease or burden of outcomes that are negative after that. I'm just going to leave with one slide here. This is a 1-year results from the first US-based ERAS cardiac surgery program. And what they found was that after 1 year, there was significant reduction in hospital length of stay, significant reduction in ICU length of stay in terms of hours. But for everybody sitting in the room here, there was a significant improvement in patient and staff satisfaction, where both parties reported better understanding of the care plan. So, just to know ERAS, yes, there's a scientific reasoning behind, in terms of medical outcome, but also from a patient and a staff engagement level, ERAS has been shown to improve that. In conclusion, nutrition plays a vital role in the good surgical outcome for cardiac surgery. Early pre-op screening is essential and correcting deficiencies. Pre-operatively, carbo loading plays an important role. Post-operatively, early feeding and daily monitoring of nutrient delivery. We know that underfeeding is a huge issue. And just to quote Paul Wishmeyer, who's a critical care specialist at Duke University, he always poses the question, are we creating survivors or are we creating victims? And we know that good, precise nutrition will equate to better functional recovery. Thank you.
Thank you, Omi. Is there any questions on ERAS nutrition?
I think the one thing we've got to be careful to distinguish, because you keep mentioning critical care and on cardiac surgical patients in the elective space are actually just surgical patients who go to ICU because they need monitoring. And that's the important thing, that they don't develop complications. But you can't equate them with a critical care patient who's lying in the ICU with a septic abdomen. I think it's an important distinction in your approach to these patients, especially the ones that we do electively. These patients are short-stay patients, and it's very important to create that distinction. I think that's the other drive behind ERAS, is to try and get, I lament the kind of silliness that a patient can go to general ICU or cardiac ICU or wherever. They can't. They're not the same. And so the whole mindset, the whole approach, the way the staff look at the patient should be different to the way you're looking at a long-stay ventilated patient who's there for pneumocystis and 16 other bugs, and the guy with a peritonitis and the polytrauma. They're not the same as cardiac patients. And I think it's important. And as far as nutrition is concerned, they're all anorexic afterwards. And the longer that they're on the ventilator and the longer that we fill them up with drugs, the slower that they will recover, and they'll be less inclined to eat. Because all the opiate stuff and all the stuff that they give them for anesthesia, patients will get a hangover from it. So that's, again, emphasizes the importance of having this whole drive. So the patients will eat earlier. They will start recovering earlier. And 6, 12, or 24 hours on the ventilator, the patients are different. Then they become critical care patients, and they're 24, 48, 72 hours on the ventilator.
Cool. I also just wanted to make a comment, and I tried to drive it very hard on our last ICU day. But I think in a lot of Omi's presentation, but as well as many of the factors involving care of these patients, we need an accurate height and weight. And it's a general practice in ICUs. Oh, it's around 90, 1.8. And we're setting inotropes and BMIs and nutrition goals and all sorts of things. Balloon pump size. We can go on and on and on about how important that is. And it's such an easy thing to achieve. Sometimes the weight can be a bit of a challenge, okay? We know that. But if the patient's not on a balloon pump or has a sheath or something, we should make an effort to weigh the patient just the one time. These patients will give you a weight that they had 5 years ago. If they're awake, and just judging it by your eyeballs, it's not good enough. Okay? We have to weigh them. We have to apply science to the way that we approach everything. There's no excuse for not knowing your patient's height. Nurses should have a measuring tape. Okay? Every single patient can be measured. It's basics.
So, hi Renee. So I think that the whole idea of introduce this ERAS protocol, we will hope to transform our cardiac ward, which is the entry point before patient being admitted for surgery, as a pre-op assessment. Intraoperatively, we've got our nurses here that, things that we can implement. So we're actually quite excited to transform cardiac surgery as such.
So the way that they do the prehabilitation in these programs that are already established, the ERAS coordinator will see the patient in an office or a venue before they come to the hospital. So when they consult you in your office, they should then go straight on to the ERAS coordinator, and then we'll draw up a system to get an accurate baseline.
Sure.
I wanted to ask Omi, just as a intensive care nurse, and I don't know if it's the right platform, but what would you look out for as a nurse now in the ICU that your patient's malnourished, like from the get-go? You showed those assessment tools, but they're not actually formalized in the hospital. So unless I bring it with me, like what are sort of general signs?
I think the obvious ones is, looking at the patient. If the patient looks, malnourished or wasted, those are the obvious signs. But sometimes even if your patient is talking, a simple dialogue about, have you lost weight recently? How's your appetite being? Because those are two big variables that then risk them or put them into the category of at risk. Or, the one thing that we find very often is if you can just ask the patient, how's your weight been like in the last 6 months? And they tell you, I've lost 10 or 20 kgs, but nobody prior to that in the 15 days of the admission ever asked that. And suddenly now you know that you're dealing with a different patient who you need to monitor closely, but also benefits from aggressive nutrition.
Okay. And what do you see like signs that you would see like on blood results and so on?
So the bloods one is tricky because we know that albumin is a negative reactant for inflammation. So in an elevated CRP, your albumin is going to drop. But if you've got no inflammation in your body and your patient is just coming in with low albumin, then that's telling you there's probably a nutritional status issue. But albumin is not accurate, so the dialogue with that patient or even the family is a better option.
Okay. Cool. Anyone else got a question about anything today? Yes?
Dr. Gordon, the other day we did an esophagectomy. What is the nutritional management for a patient like that post-operatively? At what day do we start feeding? How do we do it? Because we didn't put in any feeding
Start TPM
straight away.
until there's restoration of gut function, and then we can start some enteral trickle feeds. Because you've got to wait 5 days before you can be fed properly. It's all got to be nasogastric through the blood orders, so it doesn't reflux into the anastomotics. Or what we would often do, put a feeding duodenostomy intraoperatively.
I like that small point that Omi had about the chewing gum. I've never used that on a patient, and it's such a low risk thing to do actually. Low cost, low risk, unless they're at risk for aspiration, of course. But someone that's having issues, that's mobilizing, I think, that's GCS 15 out of 15. Try it.
That's from an ERAS paper even, they recommended that, yeah.
What pre-op nutritional
So we use Nutricia pre-op.
Is that who makes that?
Nutricia pre-op. Pre-op. It's about 20 to 30 grams of carbohydrate, and it meets so it's been developed with the ERAS guideline.
Got any glutamine in it?
No, there's no glutamine.
Okay.
Yeah, it's just got the maltodextrin. So it's more the glucose. We have some patients where the reimbursement is an issue, and even something as like an Energade or whatever, any sort of carbohydrate-based.
I just think that if we're going to use, if we're going to have this protocol, we need to have a specific, something specific. Even if we say, okay, well, we're only going to give apple juice, then,
Yeah.
or whatever it is, MJ, or whatever. I suppose some people are not going to like apple juice. Some people like
Yeah.
That's the advantage of prescribing something that is like produced by Fresenius or whatever.
Yes, yeah. So the pre-op does that.
Drink this, or at least try and drink 200 mils of it.
How many mils is required? Like,
It's three. So the pre-op is about 125 or even 200 mils, but according to the guidelines, they say up to 300 mils, 300, 315, and the patient needs to get between 20 and 30 grams of carbohydrate from that. The problem with, like in Howick, we've tried it where they give the patients the apple juice, but the patient then perceives it as a meal. I'm not hungry, I'm not thirsty. But when it's an actual product, as you say, it's part of the, yeah, it's the nurse signs it on the chart. It's all well documented that the patient has, complied with this ERAS protocol of carb loading.
How much, in 200 mils of apple juice, how much carbohydrate is in there?
We did have a look. It's between 20 to 30.
Okay,
so,
great.
It was one of the other options if patients are sort of not tolerating or don't want to take anything else.
Yeah.
Is there anything
So-
besides apple juice that delivered that amount of carbohydrate? So obviously you want clear fluid. I mean,
Yes,
apple juice is
yes.
one, but
They're
any
saying
other
that
term?
fruit juice.
Yeah,
So
on the-
you can look at a grape or a cranberry.
But the problem with some of them is that they've got particulate matter and that makes it higher risk. And
Yeah.
It's not the same.
But we could perhaps devise like a few options, and then in the pre-habilitation meeting with the patient, we can give it to them, and then they can decide beforehand, and we make sure it's there on the day.
Must remember these products were made with the ERAS in mind, the Nutricia, they've made it with it.
So that's the advantage.
Yeah,
of
yeah.
it,
And it's
right?
ticked off by a nurse on the medication chart.
And the same thing happens, it's the same old story. If we can get a consistent application of the same sort of protocol. Even
Yeah.
if we don't,
But if we explain the program to the patient, tell them you have to drink one of these before your surgery, here are your 3 options, and get their buy-in beforehand, not
And
just
have a
before,
taste of
yeah,
it.
have this. It's about education.
I know Mark and Bruce have been giving just apple juice to the patients.
yeah.
I was just wondering, Naomi, what is the approximate carbohydrate content of equivalent amount of whiskey?
It's a clear fluid.
Could be the
200 mils of whiskey.
I think most patients will go for that. And the nurse.
We have a surgeon come from Ireland. They say that those hospitals close to Guinness, they get a pint of what was that, stout, and then post-operative they say it's a high energy drink, and then patient enjoy it, and everybody has a good time. So is the patient, so is the doctor, so is the nurse. So
Yeah.
yeah, why not? But I saw that alcohol, you should avoid the alcohol 4 weeks before surgery. though.
No, it doesn't
That's a
say
problem.
post-op though.
Oh, okay.
I have heard it say that a pint of Guinness is a 3-course meal.
Yeah. Only you're out of business.
Yeah.
Okay, cool. I think that's it, guys. This was a bit of a longer session, but I think we got some cool information. I just wanted to give a shout out to Midlands Medical Center for hosting us on short notice. It's always nice to do something here. You guys go out of your way. It's noticed and appreciated. Thank you very much. And thank you to everyone who joined us on the Zoom chat. Hi, let's just wave at them. We'll see you next time. Goodbye.